Welcome, everyone, to the latest installment of EMS Focus, a collaborative federal webinar series. I'm John Kramer. I'm the director of the NHTSA Office of EMS. Together with all of our federal partners, NHTSA's Office of EMS is focused on advancing a national vision for EMS. The projects that we undertake and the resulting resources for the community help with systems improvements, measuring the health of EMS systems nationwide, and delivering data that EMS leaders need to advance their individual systems. Another role of our office is to educate the EMS community on new innovations, processes, and technologies that can help provide better and more efficient patient care. This free webinar series is a unique opportunity for federal EMS agencies and industry experts to share information with the EMS community. EMS Focus conducts webinars several times throughout the year on issues that are important to the EMS community and provides you with timely information on what federal EMS agencies are doing. Today's webinar is being recorded and will be archived on ems.gov for future viewing and listening. More information about the entire EMS Focus webinar series can also be found on ems.gov. The National EMS Scope of Practice model was created over a decade ago and defined the knowledge and skills for each of the 4 levels of EMS personnel: emergency medical responder, EMT, advanced EMT, and paramedic. The 2018 revision marks the first significant update of that model and reflects changes that have occurred within the profession of EMS and emergency medicine science over the last 10 years. While the scope of practice for EMS clinicians is formally established by the states, the National EMS Scope of Practice model provides an evidence-based foundation that many states use to define their specific scopes of practice and have in fact been incorporated into some of those states' laws and regulations. Thanks to a diverse group of experts and helpful input from many other members of the EMS community, we now have an updated scope of practice model that can help EMS systems provide consistent, high-quality care across the country. Today, our speakers will provide a brief overview of the important role the original National EMS Scope of Practice model has played since its development. They'll also share how the Scope of Practice model has been revised and some of the highlights of the new scope and how it will impact our profession. We'll also learn a bit about a new major EMS national initiative that's just kicking off, the revision of the National EMS Education Standards. We have a great panel of speakers for you today. Dan Mance served as the National Association of State EMS Officials Project Champion for this 2018 National EMS Scope of Practice model. Dan has spent more than 2 decades as the State EMS Director in Vermont, and during that time, he also served as the principal investigator for the previous edition of the Scope of Practice. Scott Bourne co-chaired the expert panel that oversaw the creation of the 2018 National EMS Scope of Practice model. Scott has more than 4 decades of EMS and emergency and critical care nursing experience. He has served as an educator for much of his career, teaching at national universities and speaking all over the country. Scott has also held leadership positions in a number of national healthcare and EMS organizations. Brian Erickson, the project lead for the upcoming revision of the National EMS Education Standards, is the chairman of the board for the National Association of EMS Educators. He has more than 2 decades of experience teaching EMS. As an associate professor of Emergency Medical Services at Tarrant County College in Hurst, Texas. He's also taught for the University of Texas Southwestern Medical Center in Dallas and served as an EMS clinical coordinator for the Arlington Fire Department. We're really honored to have these great panelists with us today and look forward to hearing more of their perspectives of the new scope. I want to remind folks that we will have time for questions and answers at the end of the presentations. Please submit questions as we go along via the message option on your screen. We'll discuss those questions following the presentation. As we get started now, let's step back in time to talk about the original scope of practice and the impact that it's had. For that, Dan, I'm going to turn it over to you.
Dr. Kramer, thank you very much, and happy holidays, everyone. I appreciate you taking some time out of what I know is a busy time of year to join us today. So if you can go on to the next slide. So why was I invited to participate in this thing? As Dr. Kramer referenced, I was the principal investigator back on the original 2007 creation of the first national scope of practice model. And to understand kind of where we've gotten to in 2018, I do think we need to go back and recall the origins of how we got to where we were even in 2007. The original scope of practice model was called for in the EMS Education Agenda for the Future, a systems approach. That document was a derivative of the original EMS Agenda for the Future, which called for a variety of reforms and directions in where EMS was going in the country at that time. Next slide. So we had been working, and I was sort of a product of growing up in this environment where scope of practice was determined by national standard curriculum. Whenever something came along that we needed to update as far as EMS practice occurred, we had to go back and rewrite the national standard curriculum. And I grew up like that, originally practiced as an EMT like that. I was fairly comfortable with that idea. And so when this whole new education agenda for the future model came along, I said to people like, well, what's so wrong with the way we used to do it with the national standard curriculum? And people would point out, well, what you've got is education driving practice. And what every other healthcare discipline does is they sit down, they figure out first, what do you want this person to be capable of doing? What's the job we're going to ask a paramedic to do, an EMT to do, an EMR to do, so forth and so on. And then you build the educational supports, the education standards by which you prepare people to do that job. So this little model you see there on the right is sort of the simplest depiction of kind of how we got to the need for an original national EMS scope of practice model. Starts up at the top with the EMS core content. That's anything and everything that could be emergency medical services. From that group, you whittle down into, well, what are the different levels of personnel who will be practicing emergency medical services? The nursing analogy would be RNs, LPNs, advanced practice nurses, and so on. And once you've set the scope of practice, then you develop the education standards to prepare the people to do the job. And underpinning all of that is a program of national EMS certification and national EMS education program accreditation. Go ahead to the next slide. So back in 2007, there was sort of common calls for consistency in some of this. You may recall, many of you may have seen the Institute of Medicine's series on the future of emergency care, including this EMS at the Crossroads document. They were calling for a common scope of practice. There was a recognized need for national accreditation of paramedic education. Accreditation is really sort of the good housekeeping seal of approval that assures paramedic candidate participants that the quality of their education is going to be reasonable and adequate. And then there needed to be a process, a national process for determination of competence, which is the national certification. You can go to the next slide. So in the 2007 edition of the National EMS Scope of Practice Model, that was the original one, a few decisions were made. It defined the national licensure levels of EMS personnel. We settled on the nomenclature of emergency medical responder, EMT, advanced EMT, and paramedic. And it was a model for states to follow in defining at the state level what EMS professionals can do. I believe, I'm not sure, I think every state now maybe has in fact adopted or referenced or bases their state-specific scope of practice on the National EMS Scope of Practice Model. It is a floor. It is not the ceiling. It is not the top of what anybody can do. Many states enable procedures and interventions beyond what the national scope model allows, but it assures that as people move from state to state within the EMS profession, other states have a reference point. They know that the person was prepared to do at least this much, has at least that much knowledge. Go ahead to the next slide. This diagram is one of those pictures worth 1,000-word things. People often don't understand specifically, how does it all work that I get to do some things and I am not able to do some other things? And this diagram shows these 4 spheres where you start at the top. You have a sphere of what the person is educated to be able to perform, what they are taught in their class. Then there's an overlapping sphere where they are certified by the National Registry of EMTs as competent. And then the state has a specific scope of practice model. That's what the person is licensed to be able to practice. And then they have to be credentialed by the medical director to determine applicability for specific interventions and use of specific tools and so forth. And what the individual gets to perform is that piece in the center where they are educated, certified, licensed, and credentialed. That's what a person is actually able to do out in the field. So it's important to recognize that there are multiple components here to determining what any specific EMS person is able to actually do. Next slide. And so then the question became, well, why do we update this now? So anytime we could publish a national scope of practice model, it really does represent a single frame in a movie that keeps unfolding over time. That as research shows new interventions to be effective or demonstrates some things we do currently to be ineffective or dangerous, the scope of practice model needs to be able to adjust. The National EMS Advisory Council Committee recommended that there was a need for alignment of the education agenda for the future, the 2005 EMS core content, the 07 scope of practice model, and then the 09 National EMS Education Standards, all needed to be brought up to date. Enough time had passed. The movie had progressed far enough forward that there was new research, there were new interventions, new tools available, better ways to educate people. And so it was time to revisit the National EMS Scope Practice Model, get it updated. I can assure you The model will hit the streets very, very shortly. As soon as it does, it will begin to be out of date. And it will come a time again, some years ahead from now, when it will need to be updated and refreshed again. Next slide. And so I think now let me turn it over to Scott Bourne, who will sort of pull the curtain back and show you the mystery of how we actually did all this. So Scott.
Thanks, Dan. I appreciate your lead into this because it's valuable for the work that we did to have some context. So I appreciate that. And I don't know about pulling back curtains, but let's talk a little bit about how this all went together. If you could go to the next slide, I'm going to spend a couple minutes here talking about the process that we went through, who was at the table and what we talked about. Or how the process worked, and then focus in on specifically what were the issues we talked about and how did we draw the decisions that we drew. Because the scope of practice influences scope of practice and clinical practice, at the end of the day, this is a practice of medicine for quite some time into the future, it was important to us that we have a knowledgeable and representative panel. I worked alongside my co-chair, Peter Talak, to bring together representatives from virtually every specialty organization that touches emergency medical services, as well as the professional organizations from those people that practice, the educators, the firefighters, the EMTs and paramedics, and so on. Next slide, please. And our goals were really fairly simple, not easy, but simple. And that was, we wanted to identify and incorporate new evidence and science. Dan did a nice job pointing out that the science had changed. There were new interventions that were proven to work. There were some old interventions that were proven not to work. At the same time, there were also some changes in community needs. Who would have predicted back when Dan worked on the initial scope that we would have the issues with opioids that we have now that would be driving needs for additional care providers to be able to administer Narcan and so on. So our primary goal was to look at the new evidence and science, hold it up to the original standards, and use that to provide modifications as we thought necessary. As good as our panel was, we knew also though that we needed as much input as we could get from the community to make sure that that input provided a community that understood what we were doing, and also they provided some great insights that we hadn't seen before, with the ultimate goal, as Dan mentioned, scope at a local level is determined by the state. So our job was to provide a tool that they could use in developing their own state regulation and to kind of even out clinical practice across the country. Next slide, please. So this process was really very open. We started a little over a year ago, almost 18 months now. And a very collaborative process. We began by looking at the 2007 scope, then went to the literature to see what the data could tell us about those things, and then create an initial background narrative. It's interesting. I think the outward view of this document is that the key to the document is the pages that say, this is what an EMR does, this is what an EMT does, this is what an advanced EMT does. For those of us that were doing the revision, we saw it a little differently. We thought that the background narrative, the explanation of why the scope does what it does and where the data came from was more important. So we worked on that first, then put that out for public comment, then began to nail down details at the individual provider levels, then onto the skills lists, and through there had 3 broad periods of public comment, and we were delighted to see that we got a lot of comment during each of those, which led to what is now the sort of final draft going through its last iterations before it's released. So next slide, just to say that input, and many of you maybe provided some input there, was critical to make sure that we had good stakeholder input, both in the narrative section and the descriptions of what the different levels can do, and then just overall the broader document. So that was really the process. And if we can go to the next slide, I'd like to talk a little bit about what did we talk about? And if there's one thing I would like to focus on in my part of this discussion, this is the slide. For everything we discussed, every individual skill, every individual level, we really asked two basic questions. The first was there evidence that that particular skill, and remember, they're not always procedures. It could be assessment, it could be clinical decision making, it could be determination of destination of transport. Was there evidence that that particular procedure or skill could help patients? Was there data that it provided better outcomes or improved patient experience? Then the other side of that same coin was, is there evidence that it can be done safely by different levels of practice? So the example I always used as we worked our way through, and it made a fair number of people cringe, and I'm guessing that some of the hundreds of you that are on the phone today will cringe, is if we were to ask the question, should EMTs do brain surgery? The two questions that we had to get from the data was, first, was there evidence that brain surgery could benefit the public? Now, I'm going to guess there's probably some evidence that brain surgery could help certain trauma patients have a better outcome. But then the next question becomes, is there evidence that basic EMTs, or excuse me, that just EMTs can do that safely? Well, there's not evidence on that. And so for each procedure we looked at, we balanced between the public benefit and the potential risk of the procedure. And we relied on evidence, a lot of evidence. We got tremendous support from a number of the members of our panel in doing literature searches and providing us with the evidence. So if we can go to the next slide, we talked about a lot of different things. This is not the complete list, but I wanted to give you a view of, this was not a narrow discussion. While we did talk systematically about narcotic antagonists, about new trends in hemorrhage control and trauma and hypothermia and CPAP and pain management, those were important individual clinical topics, but we did those discussions in light of bigger issues like, are there things happening with particular populations, whether it's the population of people using opioids or geriatric patients or pediatric patients? Were there things that we needed to consider in the scope in light of that population? We had extensive conversations about non-traditional roles like community paramedic and those types of roles, paramedics or EMTs in industrial settings, specialty care like critical care or wilderness. Those permeated every one of our discussions so that when we got ready to talk about a particular skill or procedure, did it matter to a particular patient population or to a particular level of specialty care? We talked about nomenclature. Should we continue to call EMTs EMTs? Should we change names? We had extensive conversations about whether we thought educational preparation at each level was adequate in order to allow those practitioners to do the procedures and the tasks and have the responsibilities at that level. So all of those discussions fit into the broader discussions that we had about scope and about the role of scope in these different special topics. So if we can move to the next picture, please. Here's kind of the Reader's Digest condensed version of some big changes, but I would encourage you, go to the document and see for yourself the changes that were made. Starting with those deletions there on the left, those deletions, and most of you recognize this as soon as you look at it, those deletions were largely driven by new research suggesting that those interventions no longer provided value. What that really means is they never provided value, but now the data has finally caught up. So those items were dropped from the scope because they aren't skills or procedures that offer value to patients. At the EMR and EMT level, you can see the additions to the scope. I will not read them all, but a couple of important highlights. The narcotic antagonists received a tremendous amount of discussion in light of the opioid epidemic and in light of the fact that in many communities, members of the lay public are administering narcotic antagonists. Hemorrhage control, as many of you are aware, there's been a substantial change in the literature and the understanding of tourniquets and hemorrhage control, and those really drove the changes that you can see at the EMR level and to a great extent at the EMT level. some of those changes at the EMT level reflect an understanding that many EMTs practice alongside an advanced EMT or a paramedic. And so perhaps we need to acknowledge that role as we put together the scope. If we can go to the next slide, please. There were also major changes at the paramedic level and at the advanced EMT level. Additional monitoring skills, an increased emphasis of capnography for all levels that do advanced airways, and some changes at the paramedic level based on new data on high flow nasal cannulas and some additional use for over-the-counter medications. There are more changes than those that I just described, and again, I would encourage you to head to the document to see for yourself what it says. But as you look at those changes, I want to encourage you to, and things that you maybe had hoped would change that didn't. I would encourage you to remember the foundation for our decisions, which was a look through the evidence to identify, were there interventions that offered value, and could they be safely done by a particular level? Immunizations, incidentally, came up a great deal in clinical practice since the last scope of practice, SARS and other communicable diseases. So we made changes around immunizations that enabled certain clinicians to provide immunizations if they had received the required education and were credentialed by the medical director. A reminder for all of these is that, as Dan said, we viewed these as the floor, which means they help drive education and they help drive things that we want to assure people are competent at. But individual states can continue to do things that we've dropped from the scope, or can add things that aren't currently in the scope. So overall, then, looking at a higher level and not just at the individual major changes, if you want to go to the next slide, excuse me, some other high-level recommendations. First, that we should do this more often, probably no less than every 5 years, simply because the evidence and the needs of communities change so fast. We recommended that AEMT levels be required to do national program accreditation, as the paramedic level currently does, by 2025. And we wanted to eliminate barriers for professions so that everyone can practice at the top of their level. And again, made note of some tasks should be taught and permitted at the EMT level. But if the agency the EMT works for can't afford or has chosen not to have the equipment, then those skills obviously aren't in the scope for that individual practitioner. One more slide and one more set of recommendations. As you may remember from the original description of the EMR level, those individuals were not thought to be primary ambulance providers. They were first responders who stabilized patients while awaiting arrival of the ambulance. But we did realize that in many communities, they are asked to assist in transport. So we added that in the recommendations for what's at the EMR level, but with the caveat that an EMT or higher must be present. And then a reminder to all of us who are licensed, and that is we're accountable for our tasks and practice, even if the general public is allowed to do those same things. That doesn't change it. So, and then actually the bottom one was an issue of great discussion, and that is great discussion around the use of supraglottic airways and a belief that people that use supraglottic airways must be using waveform capnography for safety purposes. And so if supraglottics are to be given to some EMT level practitioners, our recommendation was that it really always be reserved for experienced practitioners who have knowledge of and experience using waveform capnography because of the safety that provides. So again, I'd guide you to the document to look at it directly. Hopefully that picked up some of the issues that you're most wondering about. And if we want to go to the next slide, we can pass it on to Brian. Thanks.
Thank you, Scott. just a reminder to folks, some folks have already been submitting questions, but please don't hesitate if you have a question to send those in via the message function on your screen. And with that, Brian, chat with us a little bit about the Education Standards Revision Project.
Excellent, excellent. Well, thank you for having me on the call today. It's an honor and a privilege to be here. I'm hoping everyone is also preparing for a wonderful holiday season and some time for rest and relaxation. But now, next slide, please. What comes next? Well, the next thing, now that the scope of practice has kind of been nailed down, and I think from an educator standpoint, what I find most encouraging is we're allowing practice to drive education instead of education driving practice. So when we look at the model of the EMS education agenda of the future, the scope of practice is just part of that continuum of care, and documents and guidance gives us guidance and documentation to kind of help states, local officials, and educators to properly prepare EMS clinicians to serve their communities. And so now we are getting kicked off with this new project for the National EMS Education Standards, which kind of falls now after the scope of practice has been completed and is now published and ready for review. Next slide, please. As you look at the National Education Standards and you look at kind of some of the history of that, remember these first were published back in 2008. And when they were published back in 2008 and put together by the team led by Deb Kaysen at UT Southwestern and NIMSI, it outlined the minimal objectives for entry-level EMS education at all 4 of the provider levels. And it replaced the NHTSA's National Standard Curricula. And if anybody was in education at that time, realized that was kind of a big step for a lot of us. We had some issues when those education curricula kind of went away, and now we have these education standards. So now what we hope to do is take the scope of practice model, take the 2050 agenda for the future documentation, and now look at revising the education standards that were published in 08, kind of came out in January of 09. And as we start moving forward now, kind of incorporating those changes into the ed standards. Next slide, please. So what's going on right now? Well, we've identified the revision. We've been given the go-ahead to start the project, and we are currently putting together our development team. We have established the leadership of that team. The leadership of the development team right now is going to be Dr. Paul Rosenberger at UT Southwestern Medical Center in Dallas, and then Dr. Bill Young at Eastern Kentucky University. These gentlemen will be leading the content expert development team to start putting together the revisions. We have just started this project and they're just now getting into the weeds, so to speak. There are going to be plenty of opportunities for public comment. We will be just kind of like we did with scope, where we get opportunities to get educators and providers and everyone involved to comment on what needs to be in the revisions, what needs to be changed, what needs to stay in place, etc. And I just want to encourage everyone to please stay tuned for more. As we know more and as we get going with the project, we will definitely be moving forward. So that's where we stand with the Education Standards Revision. We're just getting started, and we'll be looking forward to the next about 1.5 years, 2 years getting this done, and hopefully getting this in the hands of the people that need it. Next slide. I'm going to turn it back over to Dr. Kramer for, I guess, some Q&A processes.
Great. Thank you, Brian, and thanks, Dan and Scott, as well. Again, a reminder, send in questions if you have them. I also wanted to make mention of the fact, and we have received a number of really good questions that we'll go to in just a second. But if we're not able to get to all of the questions in the time that we have remaining this afternoon, we will get those questions answered offline and get the answers back to folks. So hopefully we'll have time to get to all of the questions, but if we don't, we're not going to just drop the questions. We will get them answered offline and get the answers back to folks. Dan, I want to turn to you first real quickly, as you worked on the original scope of practice model in 2007 and again helped significantly with the update in 2018. How were the two processes different between 2007 and 2018?
Yeah.
What was different and why?
Good question. I think back in 2007, we sat down with some of the same goals, some of the same intents as we had in 2018, one of which was to use the best available evidence we had to drive practice at the various levels and to try and figure out what was safe and effective to be done by each of the 4 levels. The sort of major difference, the very stark difference in my mind, was we had very little evidence back in 2007. The literature was fairly scant, and I think as we move ahead to 2018, wow, there were just a ton more evidence-based research papers and projects to really form the foundation of what actually is working. And I think that's a really healthy indication and a piece of how the EMS profession has matured. And I think that will be even more true next time a group sits down to do this work.
Great. Thanks, Dan. Scott, this may be one for you. Actually, there are 2 that we've got here that may flow to each other. The first one, when will folks see the new scope of practice reflected, the new scope of practice model issues reflected in their clinical practice, initial education, or continuing education?
Oh, I was afraid you were going to ask me a hard question.
Exactly.
I think they kind of, and Dan will be able to reflect on this perhaps as well, but they follow kind of a ripple effect. When the scope is ultimately released by NHTSA for this is the final draft and it's out, that will lead to activities pretty quickly on the education side, not necessarily by publishers, because they may wait for the work that Brian's doing around the education standards, but local continuing education leaders, local medical directors will begin to look at what they want to train people to do in local programs. If I were a program director, I'd want to be proactive and begin to start teaching new stuff as quickly as possible and phasing out things that were being phased out. In terms of clinical practices in individual communities, that then goes back to how fast the states adopt the scopes. And if a state limits a scope and a physician wants to add to it, then that has the local practice, however that state enables physician directors to do that. So I think none of it will happen overnight, but I think there are probably some of you that are on the call that lead education programs that are taking notes right now about things you want to add or things you want to delete. Those things can often happen quite quickly. I don't know, John, does that address, you think, the essence of the question?
Yeah, I think so. I mean, it's
this is
go ahead, Dan.
This is Dan. Can I weigh in on that also?
Please do.
I think as Scott mentioned, one of the principal audiences for this scope of practice model is state emergency medical service offices, and in general, though all the states have some sort of legal, in statute or in regulation language that describes scope of practice. And so the process for states to update whatever they have in place to reflect the content of this 2018 model may take a very short time in some states, may take a year or more in other states. And so I think that's a great determinant of when education would actually begin that would reflect the content of this 2018 scope of practice model as well.
Great. Thanks, Dan. Thanks, Scott. Want to reflect for folks too. We have commented several times throughout the webinar when the document is put out, and there have been a couple of questions to that effect. The document essentially has been completed. The work of the expert panel and all of the groups that have provided input has been compiled. It's now, quite honestly, going through the final stages of federal government review. and we're hoping that that will be completed very, very soon, and the final document will be available electronically. The most recent draft that was compiled is still available on the Scope of Practice website. You see the URL there on your screen right now. I suspect that if there are any changes at all to the document as it completes its federal clearance process, they will be small editorial comments. There will be not content changes that folks should be concerned about. So I think you can, although this is unofficial endorsement on my part, the content issues in the document are unlikely to change as a result of this final federal clearance. So the most recent draft that's included on the website really will probably reflect the final clinical content of the document. Brian, I've got one for you, if you would, please. Will the changes to the scope of practice impact requirements for initial education and certification and recertification? And if so, how might those be addressed?
Oh, yeah, that's not a difficult question. Well, I think it is. I think as educators, if we look at the changes and things that are being done through the scope of practice, it will affect our education practices and what we need to teach our students. I think one of the things that a lot of people tend to kind of get worked up on, I know as I do as an educator, is what do I need to teach to make sure my students are successful? So the scope, as they said throughout this webinar, remember, this sets the floor. This sets what defines a paramedic, what defines an EMT, what defines advanced EMT. So yes, I believe that as we get into the education standards, it will drive what happens at the certification level and the practice level and the recertification level. We can kind of reflect back what the National Registry did with the updates. Remember when all the kind of scope came out and all of a sudden we had to go out and do CE and make sure everybody knew about things like CPAP, et cetera. Overall, this new scope is going to kind of drive what we do at the education level. So I think as we, the team looks at these education standards, we need to look at and say, okay, what do we need to teach our people to meet the floor? And also we need to look at what are the things we need to add into that to make sure we're producing, we want to produce competent entry-level providers at the initial education. And then on the continuing education side, you're going to need to look and see what we're teaching now that's different that was taught 10 years ago and what we need to do to bring our providers up to speed. So I think there's going to be some impact there. What exactly that impact is, I don't know just yet. May want to get a hold of me about 9 months to a year, or a little deeper in the project. We'll have a much better feel for that. But it will change and drive some. I think some folks too often get, they want to sit back and wait for textbook publishers and someone else to do all the hard work, the heavy lifting for us as educators. And sometimes we need to take a look at that scope and say, you know what, I need to be doing more about this in my EMT class, or I need to be doing more about this in my local area to meet the needs of my community to make sure I'm educating the providers that need to be prepared. Does that answer the question, you think there, Dr. Kramer?
Yes, thank you. Anybody else have any comments?
This is Dan again. As always, I have a comment. I think that the point about initial education is really well taken. There will need to be adjustments to that, and that will get eventually handled by the publishers and those folks who put out curricula and all that kind of stuff. But I think when you consider the change that the scope practice model will bring for people who are existing paramedics, AEMTs, EMRs, EMTs, so forth, some states have already exceeded what was the 07 scope of practice model. And so some of the changes reflected in the 18 edition, some states in some areas or some individual agencies and their medical directors will have already incorporated education and some of those practices into what they're doing today. So I think kind of the more nuanced piece about this really reflects the continuing education, and how are we going to assure that all of the current population of EMS personnel across the country get caught up to at least the 2018, if that is not exactly where they're practicing today.
Thank you. For anybody on the panel, oh, I just lost the question here. I will come back to it in the list. Sorry about that. Scott, one of the questions, we talk about the 4 levels of EMS providers: emergency medical responders, EMTs, advanced EMTs, and paramedics. And yet, as you made a brief reference to critical care paramedics, other folks have talked about flight paramedicine, tactical medicine, austere medicine. Why weren't those levels included in the revised scope?
That's a great question, and one that creates a fair amount of conflict or disagreement. Those were really addressed and discussed quite a lot. There are fundamentally 2 different ways that you could deal with, from a regulatory perspective, those practices. And let's use critical care paramedic as an example, but it fits all those other models as well. One is you could create a new level of EMS provider. So now, instead of having 4, you have a 5th level that's a critical care paramedic. To do that, you'd have to be able to describe that practice and identify how it's different and all those sorts of things. And that is certainly one strategy, and some states have chosen to do that at a state level. Another way that you could look at that is, in essence, this is a paramedic who has additional special skills. And to handle that, rather than a separate level, to handle that as a specialty credential or certification. We had a fairly extensive conversation about whether we thought the 4 levels still met the needs of our communities, realizing that many communities would add critical care endorsements or tactical medicine endorsements or wilderness endorsements. And we felt at the end of the day that the 4 levels were well matched to the needs of communities, and that perhaps looking at those additional skills as specialties might be a more appropriate, at least in this moment in time, way to do that. Now, it may be at the next scope of practice revision, we see that differently, but now I think we see them as opportunities for individual states to exert their influence, which is, at the end of the day, the scope is their responsibility, and to deal with those specialty areas in that way. As an aside, part of what informed us on that discussion was looking at other health professionals. Sometimes we can get good guidance from them, and when we look at physicians, when we look at nurses, when we look at respiratory therapists, and a variety of others, they have chosen to stick with the practitioner level is physician. The specialty area, be it pediatrics or neonatology or emergency medicine or emergency medical services, doesn't connote a different level of practice, but rather connotes additional specialty certification beyond the original practice. And for now, although it wasn't our mission, we did talk about it and decided at the current time we felt the 4 levels worked, and those areas should perhaps be developed out as specialty certifications. So does that cover it, you think, John?
Great, thank you very much. And you actually just touched on one of the other questions that just came in, and this is for anybody. How, if at all, will the new scope of practice affect pediatric patients?
Okay, so this is Dan. Maybe I can tackle a couple of questions that I see are coming in here. I think we had pediatric representatives on the update team we considered practice, on pediatric patients for virtually every skill and intervention. The question would come up, okay, is this uniquely, practice for adults? Does this also apply to pediatrics? Is there additional information that needs to be included in education that would make it safe for this to be done for pediatrics? And I saw a question come in that I think relates to some of this. I think the question was something to the effect of, what were the discussions on anatomy, physiology, pathophysiology as it relates to scope of practice? Those discussions were really present every time we were thinking about A-level and intervention, what preparation was necessary for that level to be able to safely and effectively perform a particular assessment or a particular intervention. And I think that's kind of the same logic about how we looked at pediatrics. Was we had to consider what is the anatomy, what is the physiology, what is the pathophysiology that a person has to be prepared on at a particular level to be able to practice safely and effectively on all age ranges of patients. Not sure whether that answered the question, but I think those two things are related, and there was a lot of discussion on it all the way through.
Thank you. We've had a couple of questions come in that relate to the fact that, it was roughly 10 years between the 2007 and the 2018 update. The recommendation of the most recent panel was that we do it at least every 5 years. There were several questions that, and I'm paraphrasing a little bit, but alluded to, why isn't this going to be done any more frequently than every 5 years? Why is it, why don't we just do it on a continual or rolling basis? One of the things that I'll provide some background and then allow folks on the panel to respond as well. One of the things that was identified very, very early on this revision process was an outgrowth of the opioid crisis that we're all experiencing. And that was a reflection of the fact that in the 2007 model, naloxone administration was limited to advanced EMTs and paramedics only, because in 2007, the only formulations that we could administer were by injection. Obviously, since then, there have been changes in formulations and confirmation of the efficacy of giving it intranasally and other dosage forms being created. But for states that have incorporated the scope of practice by reference in their legislation or regulations, to change that scope of practice to allow first responders or basic EMTs to administer naloxone was onerous in that it required a change in legislation or regulations. A very difficult thing to, or a time-consuming thing to do in many cases. So as a result of this scope of practice revision, we have created, as part of the process, an urgent update process that will allow, based on EMS need, based on science, the opportunity for a national review of needs and the ability to modify the scope of practice for limited and selected needs on a much more frequent or much more timely basis, i.e. the project would generally result in a change to the scope of practice and we need to understand that these need to be significant changes or major changes to the scope, but they can be done in a relatively timely manner, i.e. hopefully less than a 6-month time frame. And that was actually the process that was followed for updating the 2007 scope of practice model for both naloxone administration in opioid overdose cases and for hemorrhage control, to allow all levels of providers to help control hemorrhage, not only by the use of tourniquets, by wound packing, and potentially the use of hemostatic dressings. So although 5 years may not be, or may be timely for routine updates, there is now a mechanism for making major changes to the scope if we deem those necessary. I'm just looking real quickly here. I think I touched on several of those just with that review comment. Could we please reinforce the timeline on the Education Standards project, Brian?
Yeah, sure. Just so get an update here. Yeah, the Education Standards project is slated to be completed over the next 2 years. So we're getting started now. Here we're coming 19, so we'll be coming down in 21. So yeah, 2 years is the current timeline, and we have a couple of different meetings scheduled throughout the period. We'll be putting out notifications for public comment, et cetera. So yeah, looking at about 2 years to completion, maybe a little sooner if things go smoothly.
Very good, thank you. Just scanning through, I think we have covered most of the questions. There are a couple that we haven't had a chance to get to online, but we will address those offline and get the answers back to you. If folks do have questions about the rationale or need additional background or context, please send the questions to us at the NHTSA EMS office, nhtsa.ems@dot.gov, and we will address those to you individually. Again, we're hoping that the final version of the final version, I was going to say final draft, but the final version will be available in the very near future. The most recent draft, which really contains all of the clinical content issues, is still available at the Scope of Practice website. With that, I would like to extend my sincere thanks to Brian, Dan, and Scott for their wisdom and help both with the project and with this webinar. Thank you to David and Michael for all the logistics of pulling the webinar together. Kathy Robinson, who was the point person to make sure that all of the activities for the subject matter expert panel got addressed, and along with Scott and Peter Talak, herding the cats as we went through this process, and to all of the folks that have participated both on the webinar and in helping to craft the final draft or the final document for this Scope of Practice model update. With that, I will wish everybody a happy holidays. Stay safe in your personal life, and particularly stay safe in your professional life when you're out there taking care of all of the folks that we have the wonderful opportunity of caring for. With that, happy holidays, everybody, and we'll talk to you on the next EMS Focus webinar.